Hi, join me as I read on Schwartz, Principles of Surgery 11th edition, and the topic would be cholangitis. Cholangitis is one of the main complications of choledochal stones. Acute cholangitis is an ascending bacterial infection associated with partial or complete obstruction of the bile ducts. Hepatic bile is sterile, and bile in the ducts is kept sterile by continuous antegrade bile flow and by the presence of bacterial substances in the bile, such as the presence of antibacterial substances, immunoglobulin. Mechanical hindrance to bile flow facilitates ascending bacterial contamination from the bowel. Positive bile cultures are common in the presence of bile duct stones as well as with other causes of obstruction. Biliary bacterial contamination alone does not lead to clinical cholangitis. The combination of both significant bacterial contamination and biliary obstruction is required for its development. Gallstones are the most common cause of obstruction in cholangitis. Other causes include primary sclerosing cholangitis, benign and malignant strictures, parasites, instrumentation of the ducts and indwelling stents, as well as partially obstructed biliary enteric anastomosis. The most common organisms cultured from bile in patients with cholangitis include E. coli, Klebsiella pneumoniae, Streptococcus faecalis, Enterobacter, and Bacteroides fragilis. Cholangitis clinical manifestations. Cholangitis may present as anything as mild, self-limited episode to a fulminant, potentially life-threatening septicemia. Patients with gallstone-induced cholangitis are most commonly older and female. The most common presentation is fever, epigastric or right upper quadrant pain, and jaundice. These classic symptoms, known as Charcot triad, are present in about 2/3 of patients. The illness can progress rapidly with the development of shock and altered mental status, known as Raynaud's pentad. Example of Raynaud's pentad: your fever, jaundice, right upper quadrant pain, septic shock, and mental status changes. However, the presentation may be atypical with little if any fever, jaundice, or pain. This occurs most commonly in elderly who may have unremarkable symptoms until the process is already quite advanced. Patients with indwelling stents are at particularly high risk for cholangitis, though rarely become jaundice as a patent stent will prevent the obstruction of bile flow. On abdominal examination, the findings are indistinguishable from those of acute cholecystitis. Cholangitis Diagnosis. There's leukocytosis, hyperbilirubinemia, and elevation of alkaline phosphatase and transaminases are common, and when present, support the clinical diagnosis of cholangitis. Ultrasonography is helpful, as it will document the presence of gallbladder stones, demonstrate dilated ducts, and possibly pinpoint a site of obstruction. CT scanning and MRI can show pancreatic and periampullary masses if present, in addition to the ductal dilatation. However, abdominal imaging will rarely elucidate the exact cause of cholangitis, and the initial diagnosis is generally made clinically. Cholangitis Treatment. The initial treatment of patients with cholangitis include broad-spectrum IV antibiotics to cover enteric organisms and anaerobes, fluid resuscitation, and rapid biliary decompression. This is most often accomplished through ERCP and sphincterotomy. ERCP will show the level and the reason for the obstruction, and it allows for culture of the bile, permit the removal of stones if present, and accomplish drainage of the bile ducts. Placement of drainage catheters or stents can also be performed if needed. In cases in which ERCP is not available, PTC, EUS, or surgical drainage can be utilized. The selection of the appropriate approach will depend on the type and location of the suspected obstruction, as well as the availability of local resources and expertise. Cholecystostomy tubes are not indicated in the acute management of cholangitis, as the primary source of the infection is extrinsic to the gallbladder. Patients with cholangitis can deteriorate rapidly and may require intensive care unit monitoring and vasopressor support. However, most patients will respond to biliary decompression and support measures. In the current era, acute cholangitis is associated with an overall mortality rate of approximately 5%. When associated with renal failure, cardiac impairment, hepatic abscesses, and malignancies, the morbidity and mortality rates are much higher. Patients who have suffered an episode of acute cholangitis related to gallstone disease should be recommended to undergo elective cholecystectomy, approximately 6 weeks after the resolution of their cholangitis. Those whose cholangitis was related to another cause of biliary obstruction should be followed and treated for specific etiology of their obstruction, but do not necessarily require cholecystectomy if gallstones were not the causative etiology of their cholangitis. Patients with indwelling stents and cholangitis usually require repeated imaging and stent exchange to mitigate the risk of recurrent infections. So that's all for the cholangitis topic, and you will see this on page 1408 up to 1409 of Schwartz, 11th edition. Thank you so much. Please like and subscribe.